Marine Sroussi is going now to introduce to us an interesting case of cutaneous toxicity. So I'm going to tell you about a patient who had toxic dermatitis. We diagnosed in July 2013 a lung adenocarcinoma. There were no molecular anomalies, no mutations that were identified. This is the scan. So first, he went through chemotherapy through cisplatin. There was a great level of tolerance. This treatment was followed by docetaxel and other treatments, and a second line of docetaxel was given, and there was extreme progression in terms of bronchionories. Then there was gemcitabine and vinorelbine treatments, and the treatment had to be reported for a dozen of days. Then he underwent chemotherapy through paclitaxel weekly and radiotherapy, but we had metastasis. The treatment was quite well tolerated. Then after progression, he was included in the crizotinib program because it is a program targeting people who have cerebral lesions, and tolerance is marked by a photosensitivity of grade 2 that was actually dealt with by skin experts and was followed through pharmacovigilance. And at this point in time, we decided to go for pemetrexed, 500 milligram. At this point, he has a PS between 1 and 2. 6 days after the first injection, he has a fever of 39 degrees Celsius, dyspnea, cough, sputum, and grade 2 diarrhea. We're thinking of some pneumopathy, and we see an increase in CRP and a deterioration of his kidney function, but the checks turn out to be negative. So we see no infiltration in the soft parts, and nevertheless we see an impact onto the right kidney. So initial care is going to be hospitalization and isolation with antibiotic therapy. So there's a decrease in the inflammatory syndrome, but the skin reactions, the skin rashes are increasing, and the rash is reaching the thighs, the umbilicus, the back, the flanks, and the pubis. We have a couple of pictures here. I don't know whether you can see them properly. With such symptoms, we're going to turn to skin specialists. So we're going to have a test, cytolysis, and cryoglobulin of type 3, which was never described before. Following this, we mention resistance to antibiotherapies, first-line antibiotherapies, cryoglobulin, or toxic dermatitis. When we look at the treatments that have been introduced to the patients, Trixel seems the most probable in terms of the toxicity we know. So we are going to have a cutaneous biopsy with the alteration of the basement membrane and lichenoid keratosis. We don't have any edema, no vasculitis, but we've got here to conclude to toxicology. So corticotherapy started with 0.3 milligrams per kilo. That's 20 milligrams per day. 2 days after the start of the treatment, lesions are less painful, less inflammatory. There's a decrease in all these symptoms, but we have no cryoglobulin. We don't know what really happened. 10 days after treatment was started, no rash. So we stopped the treatment of 20 milligrams per day, and we decrease progressively the corticotherapy for 2 weeks, and then we have counterindications. Here we have a clinical case that I had a couple of years back, a 30-year-old patient, 2 days after introduction of pemetrexed, where we had the same thing, antibiotic-resistant reaction. There was a cutaneous tests carried out, and she was treated through antihistaminic and corticoids, and the symptoms disappeared despite the fact that she had had that rash for 3 days. And to conclude, we have a patient with grade 3 drug eruption and grade 4 hematological toxicity after only 1 cycle. And despite premedication and no toxicity during first-line pemetrexed-based chemotherapy. That's it for my clinical case. Thank you.
I'll just make a quick comment. I have a similar case of a patient who tolerated 5 cycles of pemetrexed cisplatin with no toxicity to speak of at all, and a good response. And on the 6th cycle, a 44-year-old woman, on the 6th cycle, she had enormous toxicity of every kind, including skin rash, stomatitis, hair loss, and nephrotoxicity, all of which recovered during corticosteroid therapy. Whether that was responsible or not, I don't know. But all of which recovered, but of course we never re-challenged her with the drug. There was no hiatus between courses for this patient. They were every 3 weeks, unlike your patient that had about a year in between. So I can't comment on the mechanism except for the fact that we've seen a similar finding rarely.
I would say the other thing your case nicely illustrates is the changing face of lung cancer, the ability for a patient to undergo multiple lines of therapy and still achieve benefit. Used to be 1 line of therapy and that was it, and now your patient had 4 or 5, one of which was crisatinib, which looks like that was chosen probably based on the MET amplification that you found, and seemed to have a good response to that therapy as well. And I would say pemetrexed, the skin toxicity is relatively uncommon, but we've all seen this at various points. It's become an important drug in lung cancer, not only initially, but in patients who are really benefiting and go on maintenance therapy. So I have patients who've been on therapy literally 3 years with this agent. That also has cost implications, but patients are doing well with it.
I really congratulate for such a beautiful case. It's like a horror case, right? Everything goes wrong. Just 2 comments. One is that it's impressive the CPR is 175. This looks like a vasculitis to to the infinitive, right? You see this number, immediately you look for your front, and your visual acuity. Second thing is that the pathology of the skin is very interesting. It's 3+ lymphocytes. And I think this is a reaction of the body. It's like an autoimmune disorder against the skin. So it's an immune-mediated. And but 3+ lymphocyte means that the lymphocytes infiltrate the skin, causing the swelling, the rise, the whole inflammation. So that's something very interesting. What causes that? I don't know. And then I'm sorry to say that, when I was a student, in my hospital we have corticoids for people with flat foot, flat feet. So again, corticoids cure everything, and we don't know even the mechanism. So here's an accusation. So we are like 40 years ago in this sense, cures everything, but we don't know the mechanism yet.
You have presented a nice case with a lot of data going quite fast, so I'm not sure if I got everything straight. But I would like the question I'm asking you is the pancytopenia. Does that fit nicely in chemotherapy toxicity, or do you consider that was an additional side effect? Because you're saying it's grade 4 pancytopenia. How do you account for that? Is that simply effect of chemotherapy, or is there anything else?
Il y avait d'une part la toxicité de la chimiothérapie et d'autre part il était
So on the one hand, we have the toxicity of chemotherapy, but he was also going through ACR when he came to the ER, neutropenia. Was dealt with, but we didn't associate the various abnormalities with the various events. 2 weeks after the corticoids, he was at completely normal level. But you don't think that there wasn't a self-immune reaction in this phenomenon? Well, we don't know. It's very interesting.
That's one thing very interesting. So, in your case, it was like in 6th cycle, right? In your case, 6th day, right? Mm-hmm. So this is exactly the week that takes the immune system to mount a reaction. It didn't occur like a local reaction occurs the first day, second day in any. This occurs really when the lymphocytes are programmed to attack an organ, 6, 7 days. So this may be some explanation, some antigen, whatever, in the skin, and then this goes, because it's 6, 7 days classical for immune response. It's just a comment.
Just 2 points that I'll make, Mario. In the case that I mentioned, that we had, this patient had never had much myelosuppression, but in this cycle she had tremendous myelosuppression, which made me think, for some reason, did she not clear the drug, on this 6th cycle for reasons that I never thought of. The other thing to bring out is that with the new anti-PD-1s and with many of the others, with the tyrosine kinase inhibitors, we're seeing many, many more dermatologic complications. And there is a growing field of dermatologic oncology. And I hope that this continues, because we certainly need different approaches and early biopsies to try to let us know what's going on. So you've illustrated many interesting factors and still left us wondering about the mechanism, but it's a fascinating case, and I think not one that's all by itself.
So, I would say one of the comment would be around pemetrexed. We at least in the U.S. are taught not to prescribe it for patients with a creatinine clearance less than 50 cc's, but we do that fairly commonly. Mm-hmm. But I think we have to be fairly cautious, and many patients don't have problems with lower creatinine clearances, mm-hmm. but I think other patients do. So I think we have to be cautious in people when they start to get changing renal function to use this agent, because I think the toxicity does go up in those patients. And one other comment about the cryoglobulinemia, again, interesting, but probably what we would call an epiphenomenon, probably not etiologic. This is not a case of cryoglobulinemia-induced skin rash. But when you get this big an inflammatory reaction, you get a dysproteinemia with I'm sure the patient had hypergammaglobulinemia, and in that setting probably developed some component of cryoglobulins as part of that dysproteinemia that rapidly resolved, it sounds like, with therapy.
Yeah, but you're right, it's an IgM. Day 7 is IgM, no IgG. So you go with cryo, but it's an